Welcome. In this lecture, we'll be covering two high-yield topics, diabetic ketoacidosis and hyperosmolar hyperglycemic state. Let's first talk about the pathology concerning DKA. This is based on severe deficiency of insulin, or better yet, a loss of production of insulin. This is typically seen in type 1 diabetics. Remember, type 1 diabetes is an autoimmune disease characterized by the destruction of insulin-producing beta cells in the pancreas, leading to an absolute insulin deficiency. And that is the big takeaway point from this slide. DKA occurs due to no production of insulin, absolute loss. Now, multiple things are taking place at one time in DKA. Different pathologies, different mechanisms of action, but I think we can break this down to 4 simple steps to understand exactly what's taking place. So let's begin with step 1. We have a complete lack of insulin, as we've already talked about. This leads to the inability to push glucose back into the cells, leading to something known as cell starvation. Remember, insulin's main role is to push glucose into the cells. So if we have a lack of insulin, we cannot push that glucose into the cells. When the cells become starved due to the lack of glucose, in which that they would typically use this for energy, they begin to look for other sources. Cell starvation causes breakdown of fat stores. This is also known as lipolysis. Lipolysis leads to the creation of fatty acids, which can be converted by the liver into ketones through a process known as ketogenesis. Remember, ketones are considered to be acidic. This leads to a large multitude of complications. The ketones can cause an anion-gap metabolic acidosis, which we'll talk about in the upcoming slides, which can cause a large multitude of things. But I always like to use these stepwise procedures to remind myself, in this case, that this leads to a shift of potassium out of the cells, which we'll talk about in the upcoming slides. Now, for completeness' sake, I did include this diagram, which emphasizes everything else that's taking place. But I think understanding these 4 simple steps will help really emphasize what's taking place and the big takeaway on symptoms and complications due to the production of ketones leading to metabolic acidosis. But remember, DKA occurs due to the absolute loss of production of insulin. So let's talk about the presentation that we see with DKA. This is typically seen in newly diagnosed or as a first-time diagnosis. The average age is typically a young individual, typically less than 20 years of age, or someone around that age. This presentation is typically precipitated by some sort of acute infection. This leads to a systemic release of catecholamines and cortisol. It's important to know that both catecholamines and cortisol drastically and suddenly increase glucose in the body. Then you can do this via stimulating gluconeogenesis, glycogenolysis, all these other kind of things. But we're contributing to the increase in glucose, which leads to a sudden onset of these symptoms. Other causes can be myocardial infarction, stroke, but we'll typically see infection in question stems due to the fact that not many 20-year-olds are having a heart attack or a stroke. So what symptoms do we typically see? Well, I use the mnemonic DKA can cause death fast. And that's important to know because of the fact that these symptoms are exactly that. They're fast. They're sudden in onset. This typically takes place in 24 to 48 hours. You'll present to the hospital. This will not be something like HHS, which will be a gradual onset of symptoms. So what exactly does this stand for? Delirium is the first D, or altered mental status, typically due to the moving of fluid as well as the hyperosmolarity in the body due to the increased glucose, which can cause altered mental status. Typically, altered mental status is more severe in HHS compared to DKA, but we can still see it in DKA. The big takeaway point is that it's going to be sudden in onset. We'll also see Kussmaul respirations, which are going to be deep and rapid respirations. Why exactly does this take place? Well, remember, ketones are acidic, so my body activates a buffer system by increasing respirations to try and push out CO2 or carbon dioxide, which is also an acid, to try and help the pH level. You can also see abdominal symptoms such as nausea and vomiting, sometimes abdominal pain. We can typically see this due to the metabolic acidosis. This leads to irritation of the gastric lining causing these symptoms. Dehydration is common in both DKA as well as HHS. Such symptoms as pallor, dry mouth, chapped lips, poor capillary refill is occurring due to osmotic diuresis. The body has a certain renal threshold for glucose. Typically is roughly around 100 milligrams per deciliter. When the serum level gets higher than this, or higher than 180, which we would expect in DKA, the renal system cannot filter this out. Thus, glucose spills into the urine, and with it goes water, leading to dehydration in a lot of these symptoms. This can also contribute to the altered mental status. And of course, we also get fruity breath, which is typically caused by ketones. So that's our big takeaway for DKA, the symptoms. Rapid on onset in someone who is extremely young, with altered mental status, dehydration-like symptoms, abdominal pain. You can also see more chronic diabetes suggesting symptoms, such as polyuria and polydipsia. But again, this is more so associated with the underlying diabetes itself. So now let's talk about the labs that we see. Now, there are different types of diagnostic criteria, which we'll emphasize in later slides. But right now, let's go over what labs we'll see and why. Glucose is typically greater than 250, usually no higher than 500. Some sources will say less than 600. Glucose is variable, and the range does vary, but we typically want to see it elevated in some way, shape, or form. Ketones, again, have been stressed in the pathology. We typically see this in both the serum and the urine. Which one in particular is beta-hydroxybutyrate? It should be known, if you see beta-hydroxybutyrate in a question stem, you should automatically think of one of three things. One will be DKA, which we're talking about. Two can be alcoholic ketoacidosis. And three should be starvation ketoacidosis. These two, alcohol and starvation, are kind of used interchangeably, as alcohol can lead to also starvation or malnutrition. But we typically see variable glucose ranges, sometimes even having normal glucose ranges. This is not driven by insulin depletion. This is driven by the alcohol or the malnutrition underlying this disease, which leads to, again, lipolysis, which then leads to the creation of ketones. So remember, whenever you see beta-hydroxybutyrate or ketones, always think of one of these three things. We can also see an elevated anion gap. Remember, anion gap is cations minus anions in the serum, or sodium minus the sum of chloride and bicarb. Sometimes you will have to calculate this on this exam, so I put it here for completeness sake. Normal anion gap is somewhere between 10 to 14. Some sources say greater than 12. But remember, for DKA, we expect it to be extremely elevated, in that mid to high 20s, if not even in the 30s sometimes. So you shouldn't have to really worry about what's normal and what's considered normal in test day. We'll also see a high serum potassium. This is extremely high yield to know, and the reason being is because of the fact that potassium is being forced out of cells due to a combination of three things: insulin deficiency, metabolic acidosis, and hyperosmolality. So even though the total body potassium is low, serum potassium may appear normal or even elevated in early DKA, and that's something I really want to emphasize. So why exactly does this take place? Well, insulin typically activates the NA plus K plus ATPase, and this is stimulated by insulin to drive potassium into the cells. So if we do not have insulin, we can't push potassium into the cells. So potassium is increasing the serum. Metabolic acidosis will also activate the buffer system. This will typically push H plus into the cells and exchange it with K plus in an H plus K plus exchange, leading to an increased potassium in the serum. And of course, hyperosmolarity, which you'll see in both DKA as well as HHS, is the driving force between having water being pulled out of the cells to try and dilute that concentration, and with it goes potassium. All three of those increase the serum potassium. So the big takeaway point is that the total amount of body potassium is lowered, while the serum potassium is typically elevated. And I cannot stress that enough. That is extremely high yield to know. It helps depict treatment as well as other complications that we'll talk about. The last thing we'll talk about for labs is sometimes we see elevated free calcium. We can see this in both HHS as well as DKA. The reason being is that the increase in glucose actually can displace the calcium from albumin, thus leading to increased free calcium. This can also contribute to abdominal symptoms. This is why we sometimes get abdominal symptoms in HHS, or which we'll talk about in a little bit. But I just want to emphasize that here. This can lead to a lot of electrolyte abnormalities, including hypophosphatemia, which we'll talk about. So now let's discuss treatment. So what exactly is the treatment? Well, the overview of treatment is going to be, we typically give three things: intravenous insulin, intravenous fluids, and of course potassium repletion. Now, for both HHS as well as DKA, the best initial treatment to give is always going to be intravenous fluids. So let's first start about talking about intravenous fluids. We always start with normal saline for test questions. We typically help to give back what they've lost, to dilute the serum, the hyperosmolarity, and these individuals dehydrated. So we typically start with IV normal saline, and we switch or add D5W once the glucose is less than 200. The reason being is because we do not want these people to get hypoglycemic, so we can give them just a little bit more glucose while these people are still on this regimen. The next one we'll talk about is intravenous insulin. Now, intravenous insulin is exactly that. We always give them intravenous insulin. But it is important that we do switch to subcutaneous insulin when these four things occur. Anion gap closes, the bicarb is greater than 15, the patient can eat, and glucose is less than 200. Essentially, if you remember back to the diagnostic tests or what we see on labs, we have an anion gap. We're going to expect a low bicarb because of the high anion gap metabolic acidosis. Patient's not going to be eating because of the altered mental status, and of course the glucose is going to be elevated. Once those four things resolve, that's when we can switch to the subcutaneous insulin. We typically do this for a 1 to 2 hour overlap because of the fact that subcutaneous insulin takes a little bit for it to kick in. So we don't want to just remove them from intravenous insulin and put them on sub-Q. Then they might build up a loss of insulin again and go back into DKA. So we typically overlap them for 1 to 2 hours. Then, of course, we also can give intravenous potassium. We typically only give this when potassium value in the serum is less than 5.3, and that's a big takeaway point. Remember, we expect the potassium in the serum to usually be elevated. We do not want to elevate it too much and lead to hyperkalemia, which can lead to arrhythmias and cardiac issues. So we only replete potassium once the potassium level is less than 5.3. Other things that we can do is we can give bicarb. Bicarb acts as a buffer. We do this for severe cases. Typically when the pH is less than 6.9, we can look to give bicarbonate, which will help increase that pH value. And of course, we can also give phosphorus. We typically give this when it's less than 1, when there's cardiac or arrhythmias or respiratory abnormalities. Now, the reason why we have a low phosphorus, or we expect to have a low phosphorus, is because of that high free calcium. Calcium loves to bind phosphorus. When that occurs, phosphorus that we can measure, or the free phosphorus, will be lowered. So it is also important to know that most cases do not need to be treated in the ICU. We only typically do that if they're hemodynamically unstable, there's some sort of arrhythmias taking place, or there are severe electrolyte derangements. This is the big takeaway from DKA. DKA and HHS have the exact same treatment. These three things between the two of them, which we'll talk about in a little bit, are always the exact same. Of course, for HHS, we don't have to worry about putting them on bicarb because of the fact that there is no acidosis. So there should be no reason for me to increase that pH. But everything else remains true. Of course, we don't have to worry about the anion gap closing, etc., stuff along those lines. But we always start with IV fluids for both of them. So now let's talk about the complications. Now there's a large multitude of complications. We'll talk about 3 high-yield ones. Arrhythmia is one of them. This is typically due to electrolyte abnormalities such as hypophosphatemia, hyperkalemia, and other electrolyte issues. We obviously treat this by monitoring the electrolytes as well as repleting and treating as needed. So I won't berate this too much because we've already talked about it. Cerebral edema is a rare complication of DKA, but it does occur. This leads to swelling of the cerebrum in the brain. Typically is associated in younger individuals, so teenagers, maybe young 20s, and typically more so associated with the first-time event. What we will typically see is a new onset altered mental status and potentially seizures after initiating treatment for DKA. This typically occurs because we are correcting this too quickly. This causes water to shift into the cells, especially in my brain, or your brain, causing a lot of these symptoms. So how do you think we treat this? Exactly. We typically slow the rate of treatment. Now, because this is due to cerebral swelling, we typically also want to potentially treat this by decreasing the intracranial pressure. We can do this by elevating the head of the bed, giving hypertonics such as mannitol, or even causing hyperventilation. But the big takeaway point for cerebral edema is it occurs in younger individuals, typically in first-timers with DKA, leads to after-treatment altered mental status and seizure breakthrough, and typically due to treating too quickly. So we typically slow the rate. Now, there are other complications, such as DVTs, PEs, due to hyperviscosity and dehydration, which can also be seen in HHS. but I think that these two are a little bit more high yield than those others. And of course, the highest yield one is mucormycosis, which we'll now talk about. So this is typically a rapidly progressive invasive fungal infection. So this is a fungus. Now, this is most commonly caused by the Rhizopus species. I always think of rhino whenever I see Rhizopus. So it helps me to remember the most common location, the nose and the sinus. So the risk factors are, as you can guess, diabetic ketoacidosis, but also malignancy and stem cell transplant can also take place. Now, notice how all these individuals are immunocompromised. This is more so commonly associated with DKA, more so than HHS because of the acidosis or the environment that the fungi likes to grow in. So noting that it can be also associated with other immunocompromised individuals is also high yield because you never know exactly how they're going to test this disease. Now the symptoms, I know it most commonly affects the nose or the sinus, and it's rapidly progressive. So you're going to have sudden onset of nose and sinus issues, such as sinus pain, bleeding, discharge, headache, stuff along those lines. The big takeaway point is that this patient is typically going to be treated for DKA. Maybe that resolves, and then all of a sudden, they'll develop the next day sudden onset headache with nosebleed, maybe even hemorrhage, and icky stuff coming from their nose. That's telling you this is mucormycosis. So what exactly are they going to ask you? Well, they like to either test you on the diagnosis. How do we diagnose this? Is typically with biopsy, which will show necrosis. The biopsy that we get is because it affects the nares as well as the sinus, so we typically get a sinus endoscopy. And of course, treatment. This is an aggressive fungal infection, thus it is an aggressive treatment. We typically treat this with surgical debridement, which typically takes place with the biopsy, intravenous AMP-B, or amphotericin B, as well as treating the underlying complication. Notice how I didn't say treat DKA, because this is also associated with other pathologies. Now this typically will wrap up our talk on DKA. We will now discuss HHS, or Hyperosmolar Hyperglycemic State, which we'll see should be very straightforward if you understand DKA. So the pathology here is going to be a deficiency in insulin, but not a total absence. Remember, DKA is due to an absolute loss of insulin production. This is typically seen in type 2 diabetics compared to type 1. So let's break this down into 4 steps. So step 1 is we have enough insulin present to prevent lipolysis and ketogenesis. Remember, type 1 or DKA, you produce fatty acids which are created and switched to ketones. That leads to all the symptoms. So in this case, we have enough insulin not to let that happen. We can also produce counter-regulatory hormones because we do not have enough insulin to suppress these. Notice the keywords catecholamines and cortisol again. We know that when those are around, we lead to an increased glucose production. So we're increasing the glucose over time. Step 3 is this excess glucose production crosses the renal threshold. With that goes glucose. With that goes water. That leads to severe dehydration. And then, of course, step 4, the increase in glucose, the significant increase in glucose, causes the hyperosmolarity. We'll typically see a very concentrated serum osmoles here to this increase in glucose, greater than 320. In DKA, we expect this value to be less than 320. And this leads to the symptoms such as altered mental status. The symptoms and the complications is due to this. This hyperosmolarity causes a lot of these symptoms to occur. So let's talk about the presentation. Again, this is affecting type 2 diabetics, so it typically affects older individuals instead of younger. And this is a slower onset versus DKA. Remember, DKA causes death fast, sudden onset. HHS is slower on onset. So this person will not be feeling well for days, probably up to a week until they finally present to the hospital. So the symptoms are based around the hyperosmolarity. We typically see an altered mental status, blurred vision due to the increased glucose concentration. We'll typically have a gradual onset of symptoms, including abdominal pain, polyuria, polydipsia. I do want to emphasize, if you remember what I said before, abdominal pain and DKA, the reason why we get this is due to the metabolic acidosis. We do not get that in hyperosmolar hyperglycemic state. So how do we get abdominal pain symptoms? Well, again, remember, the increase in glucose pushes the calcium off the albumin. This can lead to hypercalcemia, which can lead to symptoms based off the hypercalcemia. This is why it is gradual in onset. It's not sudden nausea, vomiting, abdominal pain. It's going to be gradual over the course of a few days, if not a week. And we typically do not see the respiratory changes as well because there is no CO2 needed to be blown off because I'm not acidotic. So typically, we'll have someone with an extremely elevated glucose, older individual, probably with known type 2 diabetes, probably very, very poor taking medications, and they'll come in with altered mental status, blurred vision, maybe some abdominal pain, and no respiratory changes. So let's talk about the labs here. I'll put up two lab values. Here are the lab diagnostic criteria for hyperosmolar hyperglycemic state, and here's our diagnostic criteria for DKA. Very similar to the labs that we went over before. So we should know for hyperosmolar glycemic state, we're going to have a glucose that's very, very elevated, typically greater than 600. Some sources say greater than 800. You'll even say 1,000 sometimes. But the big takeaway point is that we do not have an anion gap because we are not producing ketones. No production of ketones means no anion gap, which means bicarb should be normal, right? Because we're not having a metabolic acidosis. If we were, then the bicarb would be low in metabolic acidosis. And the serum osmoles are going to be very, very concentrated due to this. These four we've already talked about in length. Know this. These are an absolutely opposite of one another. If you know the diagnostic criteria for DKA, minus the glucose here or there, and you were to switch them, that is the diagnostic criteria for HHS. So knowing one will explain the other. The treatment is very straightforward as well because we've already talked about it. It is the same as DKA. I do want to emphasize that we typically start with intravenous fluids in HHS, just like as the same in DKA. The complications such as edema, seizures, arrhythmias due to electrolyte issues, DVTs, emboli, due to dehydration and concentrated blood are very, very similar as well. So I'm not going to berate them, although I would argue that typically complications are more associated with DKA than HHS due to the acuity of onset and presentation. And that concludes this lecture on DKA versus hyperosmolar hyperglycemic state.